Computer, we are good to go.
Oh boy.
Whenever
Oh,
Michelle wants to start.
well, folks. Today we are a menagerie, a gang, an army, a posse of buddies. Uh, we're absent one buddy, but I wanted to share a few teensy thoughts on something he said to me. Today it's buddy number one, producer Jake. Buddy number two, Michelle Perez, host of Pigironpodcast, along with friends, Eliza of the World, an ultra buddy, a guest, Liz Brown, a
Woo!
doctor of science and the human body, and of course, our lovely pal Lucy. There are too many buddies. Ruben is in the woods. He's just having a good old time in the woods. He just likes doing that. It's very nice to him. He camps out of his car, as you may know. There was something Ruben said, basically in a chat where we actually work out the meat and potatoes of creation of the show. I don't want to like say it beat for beat, but I was thinking about why we're doing what we're doing today. And it was something he said about when we were first, or he was basically saying something back to me, where he was basically kind of trying to draw me back from being too Twitter brained about the modern moment. That it was actually a lot of sense. Like, if we're going to actually clearly talk about these things that interest us greatly, sometimes they're very positive things, sometimes they're deep societal problems. And, well, that's what today is about. Uh, there is a tendency to just say the first fucking thing that fires out of your head, to shoot from the hip, to act unilaterally, and that's not what we ever wanted to do. And like that tendency is what we should like try to stick with within reason. And it made perfect sense. It kind of brought me to where we are today. Right now, throughout the United States and the world, it's basically several uh, back to back to back cumulative disastrous events. There is a massive, large scale war since we were last on here that has been happening in the Ukraine and Russia. All of these distinct forces at play there. It's affecting how we live in the current day right now. Massive sales hikes, massive profits, blah, blah, blah. The world keeps fucking spinning. Right now, when empire declines, it turns its sights inward for a perceived other, because you can't actually do anything anywhere else. That is what decline looks like. The modern moment in the West, all AUKUS packed countries, or countries that are all English speaking and have same aligned interests, all seem to be having the same breakdown in terms of social policy, specifically with LGBTQ people. Uh, Trans people specifically, just to get it out of the way. It just goes from everything from Vladimir Putin uh, expressly doing a speech prefacing a later speech, sort of affirming J.K. Rowling, but also talking about trans people being a massive social ill and disease, etc. We see different permutations in the West of this same rhetoric. The far right is gaining power in pretty much areas of policy, uh, local municipalities, just everywhere under the sun. A lot of people are scared, rightfully so. What I found, speaking to elders and people that had survived things like the HIV/AIDS crisis, uh, various forms of violence living daily into their adult lives and trying to live with dignity. I found, uh, you know, wish in one hand, shit in the other, see which fucking fills up first. Some of them have said, you always have imaginative and delusional thinking when you get into these really manic happy states, when you hope for the future, when you feel genuine love, when you connect to people. These are the best parts of the human impulses that make us us. But there do come times in history where a boot's coming down in your head. You're going to have to make hard decisions about your future. You cannot afford to catastrophize. You cannot be hysterical. You cannot break yourself down. You must steel yourself. You have a basic, I don't even want to say right, you have a basic human dignity that belongs to you. You are entitled to it. You deserve it. And to that end, you have to prepare. You have to learn. And you have to teach. And today we're working towards that end. Today's episode is about the often difficult and kind of gray discussion in trans experience, but it's been our oldest discussion. It prefaces our current modern big pharma debacles and like the sort of social panic surrounding the modern moment as relates to trans people. By transitive property, lesbians, gay people, bisexual people, and any and all gender nonconforming people. That's where we're at right now. And like where we want to be is where all people are happy. That is the purpose of this. This is informational, with the exception of Liz here. None of us are, doctors or medical experts. We're not qualified to give out legal advice, etc. This is us talking about this candidly, asking questions. How do you do this process? How do you initiate it? And what are resources that exist? Liz, thanks for coming on. How are you doing today?
Thanks so much for having me. I'm doing really great. I'm really happy to be on the show. I'm Dr. Liz Brown. I am a family medicine practitioner in a rural area. I do routine primary care for a wide age range, and I also do gender affirming hormone replacement therapy on an informed consent basis. I am personally trans, and I ended up transitioning shortly before I started my medical education.
Oh, wow.
Yeah, that was a wild ride.
I can imagine. Well, no, fuck, I can't. I cannot assume a first person on that. I can barely do most forms of simple math.
A suit you've already taken in a size hanging off of you.
Okay.
That was the end of interview season was dodgy.
I mean, I'm like imagining everyone I can visualize on the Zoom call in some sort of David Byrne, like oversized suit. So it follows.
Yeah, I mean, it worked. That's the best part. That's why it's funny.
Fair enough. I kind of, I'm obviously going to open it up to everyone, but like, I kind of talked a little bit about the why, but for you as a clinician, in terms of DIY care, why would someone want to do this? I kind of want to talk about this like we're introducing this shit to an alien.
I think that's a great place to start because authority is really tied up in medical culture. There's a lot of ideas that lay people and health professionals have about, well, what should you do? What shouldn't you do? What's the right way to behave about your health? What's the wrong way to behave? And I think that there is a moral and normative aspect attached to that. That's, especially in our context where we're deprived of healthcare we need. We often can't count on a safe relationship with a medical professional. At the end of the day, you got to do something. So, in our community, going back decades, there's been a lot of back and forth between people. It's not something that's ever been resolved. Like, are we okay with self-meding? Do we condone it? Would you ever recommend it? And from my perspective, it's not about recommending or not recommending. I mean, I personally have had a gonadectomy. So if I lost my access to hormone replacement therapy, I would, one, feel terrible. and two, start to develop osteoporosis and other accelerated aging related diseases on the order of 12 to 18 months. So for me, it is a matter of life and death. If I can't get legitimately prescribed and manufactured estradiol, I got to do something. And for people who are coming out and recognizing their dysphoria and their identity, this is my experience, this has been countless trans people's experience, not even the doctors we have access to, you know, the clinics, the providers we have access to, but the entire cultural edifice of accessing gender affirming care is deeply alienating and often unsafe or just inaccessible. So people will be in regions of the country with insurance, with financial situations where they, for one reason or another, need to be on hormone replacement therapy. And for one reason or another, they cannot find a legitimate medical relationship in which that can be started, continued, and monitored. They still need the thing, basically. And this has been recognized in the medical standard of care for gender affirmation for trans people, in other words. Since 2012, the WPATH Standards of Care version 7, there's maybe more to say about WPATH if we find time for it, but what's considered the current gold standard recognizes that people are going to potentially self-med, that not prescribing isn't a benign action. It's not, you know, inaction is not neutral to patients. And it also pretty clearly outlines that we as clinicians have a harm reduction mandate. So we have to be flexible and adjust our thinking and our rules in order to do the most good for people. And to recognize that, you know, by the time someone might actually get in to ask for hormone replacement therapy, they've in all likelihood, you know, crossed a number of profound barriers, even if it's our first experience with that question or with that question from that patient.
Okay. Yeah, I was about to say in terms of the moment, I don't want to get into the culture war aspects of it because it could just be like a actual minefield of just talking about the most fucking insipid tweets. I would say there is a tension that I think is being unpacked in the media, whether or not it's sincere, bigotry, etc. We see this with various clinicians kind of doing the heterodox label, etc. It kind of coming into conflict and tension. Yeah.
Even if all of that were cut out, because I mean, the fact that the medical institution is the source of hormonal affirmation for trans people means that we're dependent on medical care if we're trans people who need hormones or want hormones. We have to convince a clinician to do something for us that isn't just treating a medical problem, but is integral to who we are in a certain way. And that creates profound tension with authority. Even without all the prejudice, the hate, the gatekeeping, I think we're in a position where for medicine to recognize our autonomy in the way that I really believe it should for all patients, but doesn't, would make a huge difference in this.
Okay, yeah, I was about to say, because like right now, in terms of like outcomes, I think the main thing I personally think about, because most of my needs are being met personally, are the policy outcomes, because it could just as easily go in a direction whereupon, I have friends that could and have said, if it gets really hairy and you find somewhere else to be because this is an existential threat, we can help you with bridge shit. But I think about that. I don't necessarily feel guilty that I have people in my life that can help me on that. I think of how many people do not have that resource, and like what is like a reason and like considered path towards like knocking that out.
Or self-medicating?
Yep. If it comes to that.
People can buy hormones, all of the components for hormone replacement therapy online. There are countless international online pharmacies that are reputable in India and Cayman Islands. They are selling the same prescriptions that are produced and dispensed to patients in those countries under compulsory license laws. There aren't, epidemics of drug poisonings in those countries. So provided, it's hard to endorse the safety of any one of these sites. They all operate in somewhat gray legal territory. But the simple fact is they sell real hormones that people can simply buy. And the legalities are complex, but the fact is that people don't routinely get picked up, at least, knock on wood right now, for ordering hormones for gender affirmation off the internet. It is very much a possible thing that people do all the time. And even, before I was starting HRT proper, when I was trying to get on finasteride to kind of feel things out and also pause hair loss, I couldn't get it covered on my insurance or affordably domestically, so I just bought a bottle online. It is a little bit more complicated with testosterone, thanks to one Joe Biden making it a federally controlled substance. And with my own background, I'm a little bit less personally knowledgeable of how people tend to acquire testosterone, but I know for a fact many of these sites will also sell testosterone vials, gels, patches. It would be objectively worse to be caught importing a controlled substance without a prescription, but people got to do what they got to do.
Yeah, that's one of the wild things about the modern moment. I can't speak for everybody, but I feel like we're mostly on the same page on stuff. I'm like a
there is
legalize
a question.
all drugs person, but yeah, go off.
Yeah,
please.
there's a question I had just regarding what Liz just said, as far as so you're able to use the internet to order this product from a different country. Is the point of legal ingress, the point of gray area, the fact that technically this getting shipped to whoever is receiving it, it should not, it should only be prescribed within the US, and they are subsiding that?
There is legality to ordering medications for personal use.
Okay.
The idea is you're supposed to have a prescription.
Right.
What I've gathered most commonly happens when there's a custom seizure is you get a letter asking, hey, where's your prescription? And if you can't produce it, that's really the end of the matter. You just don't get your shipment. Now, this is a game of Jenga because the government is capricious. They have a lot of leeway in what they can do versus what they care to do. So if things heat up for us more, and for people who might be importing larger quantities, and for testosterone in particular, I don't know quite as much how much that holds or how common seizures are. So these are all unknowns, and they can be potentially potent ones. The safest thing to do, if possible, is to get a prescription written from someone somewhere, so you at least have that backing you, whether it's a telemedicine doctor, whether it's a and in the US now, at least since COVID, that's taken off in a way that makes it much more accessible. If you can get one consult, one paper prescription, just something that would provide some backing. There are a few situations, I think, where the ability to do that wouldn't also come with the ability to keep having a better than nothing medical relationship to get your medications in, though. So I'm talking about some edge cases there.
Right.
Yeah, and then some of these services, they'll do a sort of very pro forma e-consult where maybe someone in a call center who happens to have a degree in another country will call you up and discuss the problem and then author a prescription that, again, may have some pro forma value. These are all situations where you don't want the eye of Sauron on you if you're either a layperson or a professional.
There is a lot you can get away with in terms of just writing the letter yourself, because quite often they are not actually calling that doctor's office. They are not actually checking up on you. They have the letter, it's good enough, they'll go ahead and do whatever you need to do. And that's true of not just prescriptions, but literally everything in this gay life. If you write a convincing looking official form, you can get away with a hell of a lot of shit. And I've gotten pretty good at photoshopping documents at this point. I will say that anecdotally, I knew someone whose boyfriend was buying a shitload of research chemicals. And this was not a hormone situation. This was straight up like Soviet benzo molecule type stuff. getting them
Yeah, you
shipped
don't want to move
to
volume with that.
yeah, getting them shipped to his actual address, which is really fucking stupid, under his actual name, taking absolutely no precautions whatsoever. And DEA got him. And here's what getting him consisted of. 2 agents showed up at his house, sat him down, and said, and I quote, this was quoted verbatim to me. They said, "Are you kidding me?" And they just scolded him and basically said, "Stop that." And then they left. There were no charges filed. Nothing happened. And this guy he was not dealing in like dealer volumes, but he was dealing in significant Redditor drug hobbyist volumes, which
Oh
is,
no.
he was one of those guys. So that, and the fact that I have been sort of keeping an eye on the subculture for a long time makes me think that, again, with the exception of testosterone, which is kind of a different level, also very much harder to get, so it's less likely that you'll be able to get that yourself in the United States
I
anyway.
can say, like, yeah, same, being part of these communities for a long time, I've never heard of anyone getting
I've
significant legal or criminal ramifications for importing hormones.
Me
That's
neither.
a point I was interested in, just because
People are very
Not one.
paranoid about this. There's
Yeah.
there's this sort of sense of paranoia in younger millennials and Zoomers in particular of like, I'm going to get in trouble if I download this torrent. I'm going to get in trouble if I buy this thing online from the gray market.
Mhm.
In all of my years on reading drug internet and blue light and the crackhead clubhouse on Something Awful, unless you are importing heroin, I've never ever seen anyone get busted.
Yeah.
I saw a couple people go down for RCs, but it was really, really just over the top stuff.
There's a joke somewhere about, and I forget who told it, about how the USPS is the biggest drug shipment company in the world.
Yeah, Mitch Hedberg.
Absolutely.
So
R.I.P.
yeah.
And even like there are very minor things you can do to protect yourself in terms of
That was Mitch Hedberg.
cash PO boxes and using somebody else's address and that kind of thing.
And
I
if
don't
it's
think
not
that stuff
supposed
is.
to- Sorry.
I was going to say I don't think that stuff is strictly necessary for most.
If you
most
weren't
things.
expecting a signature on delivery, don't sign.
Right.
That's a good point.
Another thing, I mentioned the harm reduction mandate a few minutes ago. Something that I think, an audience that's considering self-medding could use permission to do. A harm reduction mandate means that if you come to your doctor and you say, hey, I've been self-medding, I need lab monitoring, or ideally a prescription to help keep me safe, that's what the standard of care says they should work with.
Just for a little bit of clarifying it, I've heard that this can be a little more muddled in, say, the UK.
Right.
I don't think we have a massive contingent of UK listeners, but I do want to add that caveat that
that's a really good point.
Like
And
you're speaking
Australia.
of, Australia, they have different laws. I do mention AUKUS pack countries like this because I'm not even trying to wrap it into a conspiracy-based thing, but they all seem to be having the exact same policy discussions, and
it's been about $4 billion spent globally.
Oh yeah, I mean, yeah, you're probably talking about those philanthropic numbers that they were throwing out.
Yeah.
Yeah, evangelical Christians and dominionist Christians, as you know them. These people have tendrils in pretty much everything. Think of certain types of discrete, like leftist groups, if you could believe it, and shit. Stuff like Wolf. Oh boy.
So in the UK, informed consent-based prescribing is almost unheard of. They don't follow WPATH. In fact, they go out of their way to reject WPATH and more modern standards of care within the gender clinic system. And they all but have a policy of penalizing people who, quote, break their rules and depriving them of care if they have suspicion or now the tough thing is it's a gamble. You don't know if the person you're trusting is, on the level or not, if they are compassionate or can be influenced by such considerations as common sense or not.
Moreover,
in the US, the one advantage we have with our really fragmented system is to a certain point, if you have a bad experience with one primary care provider, you can go pitch your story to another primary care provider.
Mm-hmm.
And you should feel fully free to do so and not, stuck with someone who maybe shows total disregard for your health if you do pitch something like this.
Yeah.
Especially with, one of the medications that people commonly import that unfortunately I can't prescribe as an anti-androgen is cyproterone. Cyproterone fell out of favor because it can cause pretty significant liver issues. It turns out that at lower dosages, which are still effective, this can be monitored pretty safely, but you do need labs. So that's a situation where there's an extremely compelling case to say, look, I'm buying this stuff and I'm taking it. There's nothing you can do about that. I am asking you to, order a liver panel every few months to help me not die.
Okay. That's kind of the wild thing at play here. Philosophically, that's what it seems leads a lot of people to the DIY path, because a lot of doctors fight people tooth and nail on this, and depending on the area you're at, I think of Texas specifically right now. You don't really get to have that fight or have it out in that way, given the specific nature.
I had people come to me from Arizona saying they treated estrogen like a controlled substance.
Yeah, it's at a point now where, God, I'm sort of staring down the barrel of God, where I'm at. Like, they're giving me hard dates for when I can get spironolactone again. It looks like everywhere's hedging their bets on this. They have the supply, but now they're wondering if people are doing stores for other people, etc. I'm
very
fairly
relieved
certain.
I haven't heard of any of that in my neighborhood yet.
Oh, well, right now it's also a matter of probably switching providers, but also maybe changing pharmacies. We'll see. I don't want to waste too much more time on that. What I would say,
Right. All of this takes work and effort.
yeah,
We've barely begun to even talk about the amount of work that patients in general in this country have to do to get anything done for their health, to get anything covered.
That's one thing I
It's like
wanted to
pulling
ask
teeth,
about
every little thing.
with regards to what you said with patients coming from Arizona and having estrogen treated as a controlled substance. You just to clear this up for my own stuff, you previously stated it's not a controlled substance, right? So
It
is
is
that
absolutely not.
so that's basically a state interference level or a individual
No, it's a
interference
cultural
level? A
thing.
cultural, yeah, that's basically what I'm
Um,
trying to say is that, like, yeah, and what can one do against that, right? They
So
can say it's
physicians are
illegal,
barely
but
educated on this stuff in
right.
general. And it was worse for an older generation of physicians. And
Mm.
this is in part because some of us genuinely don't want to hurt people. When something is exotic and unknown to us, the
Sure.
perceived risk gets inflated.
Sure.
I think that the Framingham Heart Study, which sort of reversed a lot of people's opinions on postmenopausal HRT, had an impact as well. I think a lot of people heard increased risk and didn't understand what the absolute values were or the other things that are worth talking about that study.
yeah. A common one I always hear is trans broken arm. Like in the day, do you remember that one at all? Basically,
Sorry, what?
trans broken arm.
Oh yeah, we still deal with trans broken arm syndrome.
Yeah, basically, I would like prescribe you this or that, but I genuinely don't know how this would interact with someone taking this hormone regimen, blah blah blah, such and
I don't want
such.
to tamper in God's domain. Or I
Where-
don't want to give you breast cancer by giving you breasts.
Where it's like, you've dealt with menopausal people that have had broken arms. This is not out of your wheelhouse.
Yeah, it's not complicated is the thing. Like it's really unlearning for most healthcare professionals, not learning. The learning is a small component of this that you could cover, with an hour or two of reading. The unlearning is, understanding that trans people are basically normal. And, that our concern when we seek medical care, first and foremost, is not being abused.
Yeah. I will bring up at this point because it is relevant. Something that has helped me a lot with access, not for hormones, but for chronic illness and sort of occult illnesses as in just stuff that doctors know about and don't want to treat because they don't know anything about it, which has some crossover definitely, and also because a lot of trans people have chronic illnesses for many reasons. One of the things I have found that helps is that I will do the research myself. I will go to PubMed, I will type in the relevant terminology, and I will read up to my level of fluency and get help with anything beyond that. And actually, Liz and I have been friends for a really long time, and her going to actual medical school has been incredibly helpful in my life personally, because if I don't know what I'm reading, I can kick it over to her and she'll explain it to me, which is just something that she does out of the goodness of her heart for me.
It's also what I love about primary care. It's what I love about what I do, is navigating that with people.
Yeah. So when with these papers in hand, and I use a website called Sci-Hub, which we will put in the episode notes, to get JSTOR access and access to full articles that I normally would not be able to get without paying hundreds of dollars to get past the academic paywall. I read these papers, I come to my own medical conclusions, and then I bring my evidence to the doctor. And I don't snow them with paperwork because you also don't want to look crazy. It's a fine line to walk between I've read oh, you went to medical school, that's cute. I've read over 5,000 posts. You don't you don't want to do that. But bringing an actual peer-reviewed large sample size paper study to a doctor and saying, hey, I was just reading about this, and this actually looks like some good evidence-based medicine of the subject that we're talking about. Could you take a look at this and let me know what you think? And there's some social engineering that goes into this as well, because doctors have a culture of their own, and part of that culture is that they want the patient to be compliant and they want the patient to recognize them as an authority. So there is a way to approach the doctor for a lot of these things that I find works socially for me best, and that is to say, I've done the legwork for you, but I'm still recognizing you as an authority, so I'm just going to make it very easy for you to say yes to my request. And that has worked for me very well in accessing experimental drugs, accessing drugs that are being prescribed off-label for stuff, and also in making the doctor confident that I'm informed and that I'm giving informed consent, which is something that they worry about a lot, because without going to medical school, there is an argument that patients are sometimes, in some situations, if they don't actually understand what the medical condition is, it's difficult for us to make informed consent, excuse me, because how can we be informed without understanding the science? And that's a valid argument to an extent. So, not everybody has the time or the background to do this. I'm a huge nerd, so it appeals to me to do things this way. It's just one tool that people can access if they are able to do so. So Sci-Hub is great. Read those papers yourself. Get educated. Know what you're talking about when you go into the doctor, and it helps. It has helped me. So I just wanted to say that.
Incredibly well put.
Absolutely.
It shouldn't be necessary, like as you say, like this stuff creeps in even despite our best intentions.
Right. It
Some of
definitely
it
shouldn't
also
be necessary, but I do want to say that, especially now with COVID, and also of watching you go through medical school and hearing about what that was like, I've gained a better understanding of why doctors make seemingly illogical, irrational, or even malevolent decisions. Sometimes you're just fucking tired. Sometimes the doctor has been on 4 days of shifts. Sometimes the doctor has 50 patients besides me, and the other patients are bleeding, and I'm the guy that has irritable bowel syndrome and some sort of somatic stress illness that's, making me break out in hives or something, So I have a better understanding of why doctors are the way that they are about this stuff. And I have more empathy for them, I think, which ironically has helped me get doctors to do what I want them to do. Because now I'm also coming at them from an angle of, hey, you know, I know what you're going through. It fucking sucks. I did the work for you. You can just skim these papers and tell me what you think. So.
Yeah. No, it really does work. It works on me. It works on other doctors because we're drilled into thinking like this.
Oh man.
Yeah.
I was about to say, so I kind of wanted to I guess we could kind of go through a sort of sample of this, because I feel it's sort of important to talk about actual methods in which one would be ingesting HRT drugs. I wanted to go through just two basic, the ones we all know and love. We have the trans feminine routine, and you've admitted, while you don't have an explicit super exhaustive knowledge of trans mass care, you had mentioned those drugs earlier.
I mean more as from a self-med perspective.
Okay. Which is absolutely fine. We want to have that caveat there in the case that we'll probably deal a little bit more with trans femme care. To that end, with regard to trans femme HRT, can we kind of loosely go over the ones that are available or the ones people use,
here's
and
the
how they are used?
The most accessible and cheapest form of estrogen is tablets. Any generic for estrache can be taken sublingually. So any source of micronized estrogen can be dissolved under the tongue rather than taken orally. Oral estrogen is the least effective and least safe way to take estrogen because it sees the liver first. The liver ends up chewing up about half of it. So your body gets about half the dose, and then the liver is reacting to the full dose. And one of the things the liver does in response to estrogens is it makes more sort of lipid regulating proteins. It makes more clotting factors. It also produces something called sex hormone binding globulin, which reduces available estrogen in the periphery. So it's sort of a guard against estrogen overdose. So sublingual method of administration has an advantage in that about 70% of it skips that process. So it's considered comparable to injection or transdermal. There's a lot of controversy over that, and probably different people respond different ways. In general, I think it's important to try and find some way other than oral to get your estrogen, if at all possible, and to avoid conjugated estrogens like Premarin, which we used to use. And they're just more likely to cause clots with no additional benefit.
Okay.
So patches, injections, transdermal. With all hormone injections, we used to only administer them intramuscular. About like 5 years ago, someone finally bothered to study it. You can do all of them subcutaneous. It's the same dose. It doesn't matter. So that's usually a smaller needle, usually more comfortable. Another tidbit here with...
Let me break in here just real briefly. Intramuscular is jabbing somebody in a muscle with a needle, which hurts quite a bit. And subcutaneous is jabbing somebody into a fatty part, which does not hurt as much. So you would do the injection with a small needle, like Liz said, in, you know, upper arm, thigh, belly, somewhere like that. I'm just putting in the super low level layman's terms here, because I know that
like an insulin injection.
A buddy of mine actually takes like shots on a pretty soft part of the butt, for example.
Mm-hmm.
Yeah,
any both can do.
I usually go for the butt because it's just there's not a lot of nerves there. Yeah. Anyway, sorry to interrupt, Liz.
No, it's okay. So sublingual estrogen, the one thing I wanted to add on that, a lot of people think that they have to hold it under their tongue until the tablet is totally gone, which will never happen. Really, once the tablet starts to crumble, you've got most of the job done. So like 5 to 10 minutes with that. Traditionally and typically, trans women also use an anti-androgen. The rationale is that that makes things happen faster and suppresses testosterone. There's some controversy over whether that's quote unquote necessary. I tend to recommend it. Spironolactone is the main accessible anti-androgen used in the US. It is an ancient drug, which is good and bad news. It's primarily used as a diuretic, so it makes people tend to urinate more, can cause some issues with blood pressure, especially when standing up quickly. The biggest risk with spironolactone is potassium elevation, which is really uncommon in healthy individuals who don't have kidney disease. We don't recommend people go on a low potassium diet for it anymore. It is a really good idea to get at least one potassium check on a given dose of spironolactone, especially for people with kidney disease. People on spironolactone should also avoid a medication called Bactrim, which is an antibiotic we use for UTIs some of the time, because it mimics the same effects on the kidney and can increase your risk of high potassium, which can be fatal. And then many trans women also use progesterones for mood, libido, breast growth. Sometimes, people's medical providers will be more iffy on that than other elements of HRT. Really, the biggest risks with progesterones are low mood. Some people don't really truck with them. They end up feeling really bad on progesterone and progestin medications. There's a ton of different ways to take progesterone. In the US, it's mostly medroxyprogesterone and something called prometrium or bioidentical progesterone.
Yeah, I mean, the ways to do it, I've heard, basically eating them. I heard of one sublingual, but the one you hear of most now is boofing. Just putting up the old
and
butt.
I gotta say, I don't think that's wrong. It sounds like a lot of work. And what I would recommend people consider is that the prometrium capsules are already dosed at high numbers to overcome the poor oral bioavailability. So if rectal administration does work as advertised, you'd really be delivering a super physiologic dose of progesterone.
Have you
which is
had
still
any...
unlikely to hurt you. If you feel good on it, it's fine.
I was wondering about progesterone is completely unregulated. You can buy it over the counter, and it's marketed to cis women for all kinds of stuff. So I actually have a bottle of progesterone cream.
Yeah.
Do you have any experience with using or your patients using progesterone cream in a course of HRT?
Honestly, because I'm usually able to prescribe medications and get them covered. I usually just go with prometrium. I had someone recently where I was exploring injectable progesterone, but I haven't really considered the cream.
Okay.
That will probably come up in my practice next time someone has a cost barrier to prometrium.
I have noticed just for myself, I'm assigned female at birth. I've got, uterus and boobs and all that stuff. I use progesterone cream topically. It can help with menstrual stuff. There's a neat trick where you can use it to, like if you're going on vacation or you have a hot date or something and you don't want your period to come and it's scheduled to show up, you can apply progesterone cream to keep it from showing up for a few days if you want to. So there's a lot of little hacks you can do with it, but you can buy it at CVS. You can buy it on Amazon. It's pretty cheap. Obviously, dosage is really pretty crazy with progesterone cream because, it rubs off on your clothes and everything. And of course, there's always a risk with topical hormones that it can spread to other members of the household if you're touching other people. So that's just something to be aware of. But it does work. It has hormonal effects on me that are completely detectable. So I just wanted to bring that up, that it exists, it's out there, it has zero barriers to acquisition besides getting it physically in your hands. So
yeah. And there are other anti-androgens that people do use, commonly seen in self-medding. So cyproterone, I mentioned, there's another one called bicalutamide, which we still do use in prostate cancer. It's become more popular with endocrinologists in the US. I have a lot of caution with Bical because it causes two kinds of liver failure. One is similar to the kind you can safely monitor for, like with cyproterone. And one much less common kind is an irreversibly fatal autoimmune hepatitis. So people on Bical occasionally draw a short straw that ends in transplantation or death. So I try very hard to shy away from proactively recommending it, even though I've heard wonderful things about it for the vast majority who take it.
So I have a question. If someone is doing DIY HRT, at what point should they seek medical assistance? Like, what are some symptoms that they need to get themselves to a professional and get looked at? Signs that things might be going wrong and they need help.
Well, the biggest things would be, if they're on spironolactone, if they're having heart palpitations, muscle weakness, muscle cramps, repeated fainting that doesn't improve with better salt intake and fluids, things like that. With estrogens, the biggest concern would be venous thromboembolism. And just like if you're not on estrogens, if you're having, would be a blood clot. So just like if you're not on estrogens, if you have a leg that's suddenly swelling and very painful, if you have new shortness of breath, rapid heart rate, these are all situations that might be a medical emergency. My thinking in terms of trying to seek medical counsel, someone who is self-meding, of course, the ideal would always be being able to establish a trusting relationship with a provider. It's just a judgment call when the time might be right again to seek that out.
Okay, thank you.
Yeah. And then we can talk a bit about testosterone, a few different forms of that. That's typically the backbone of a masculinizing HRT regimen. You don't have to worry about anti-androgen or anti-estrogens in the same way. So testosterone is used as a gel, androderm or testem. It's used as a patch. Androgel or androderm is the patch. And then it's the injectable forms. There is an oral testosterone that's very promising and probably just as safe as sublingual estradiol. It's on patent and incredibly expensive for now.
Okay. So personally, I will say that I recently went to Planned Parenthood, and I live in Washington State, in the Seattle area, which pretends to be super liberal, but actually Washington State has a very good Medicaid. And I'm on state Medicaid, and I recently just walked into Planned Parenthood. Well, I made an appointment and talked to the doctors there and said, "Hey, I'm transgender. I'd like to start on testosterone." And they just asked me. They were 100% professional, friendly, non-invasive. Didn't use any weird language with me that made me feel strange. And they asked me the basic questions and gave me the prescription, and I just walked out with a testosterone prescription that day. It was that easy. And I think that that's going to be true in some clinics in some states at this point, which is great.
If a patient is ready for it, I will routinely prescribe in a new patient appointment. No big deal.
Yeah. So,
and I've heard great things about the Planned Parenthood informed consent practices too.
Yeah, I was really impressed. I had heard good things too. And so I got Cypriodate, which I always want to pronounce Cyprianate because the Cyprian is, or Cypriot is one of the one of the euphemisms for Aphrodite. Actually, it's there's a mythological connection there, which I'll get back to maybe later in this episode if we have time. But yeah, Cypriot, and it was in cottonseed oil, which I was a little suspicious of because cottonseed oil is, for a lot of people, particularly people like myself who have consistent allergies and just autoimmune flare-ups and stuff, it can be pretty allergenic. And I'm not sure if I psyched myself out or if the reaction was genuine, because sometimes allergies are somatic. But it did immediately start causing, I got a cough, I got just sort of some inflammation reactions to it. So I stopped taking it, and I need to go back in and try a different form, see if they can give me a different compounding oil, or maybe just try some topical stuff.
I believe testosterone enanthate is in a different carrier oil.
That's what I've heard. And there's one that starts with an X, I think. I can't remember what it is.
Dodecanate.
Yeah. So I actually did some reading about it and found on some forums of cis guys who were older guys who were doing testosterone replacement that they also had, many of them had been getting the persistent cough and the allergenic reactions. And the persistent cough is often written off for example, on the trans mask subreddits as, quote, the T flu, unquote. And it is often attributed to, well, that's just your voice changing, don't worry about it. And the fact that it started happening immediately after I injected and my voice didn't change at all, there was no time. That's something that usually happens on a slightly longer timeline for most patients. Makes me think that probably there are more people out there who are reacting to cottonseed oil or maybe some of their other compounding materials that are just writing that off as part of the hormone effects as opposed to an extrapyramidal effect that could be causing an allergic reaction. And I bring this up because it's something that you should weigh in, are these potential effects worth, the trouble that I'm taking to take the hormone, but also because autoimmune disorders are very, very common in trans people, as I've mentioned. And part of that is just stress, lifestyle stress factors, etc. And part of it is maybe something else, but that's kind of a wingnut theory on my part, which we don't have to go into on this episode. But if you are a person that, has ever had like anaphylaxis or anything like that, maybe you do your first testosterone injection around somebody who can keep an eye on you just in case you have some sort of a reaction. I really haven't heard of people having like big full-scale reactions to tea.
Yeah. I've seen people with hives. No anaphylactoid reactions so far. But that's a really good point, and something that, again, I'll probably end up checking in a little more carefully with people in clinic about.
Yeah, I don't think it's a huge issue. I think if it were a huge issue, we would have heard about it.
Yeah.
But
this is where like the benefit of being able to work through things holistically,
right,
like really shows is, you need people who are not going to say, well, I guess the hormones are just bad for you. Or,
yes,
I guess that's just what comes with tampering in this domain. You need someone who's going to look at the components and the different potential explanations and, how do we sort this out?
Mm-hmm. And particularly if you're a patient who is dealing with other chronic conditions, it becomes this spinning plates thing of managing a bunch of other symptoms and then adding a potential irritant on top of that. And it's like, you just want to be able to know where your symptoms are coming from in case they get bad and you need to control them in a different way. So,
yeah. I mean, I thought of that as like a small anecdote here. Like I thought of all of the sort of weird early COVID talks on Spiro, and then the regular taking of Spiro possibly maybe lowering or heightening some sort of level of resistance to COVID that obviously didn't seem to really go anywhere. It didn't really make us stronger or weaker comparatively to it.
I think was that it would increase expression of acetylcholinesterase receptors, which the virus needs to enter cells.
Yeah, like that was the premise made. I don't really know if anything came of it, but like it
hasn't held water.
No.
The estrogen being protective thing though, that surprised me. It actually, yeah.
There was a rash of right-wing guys saying and paying for basically pink pilling to fucking stop COVID. No, it's Gynecomastia.
So funny.
It's Gynecomastia. I swear to God.
Who keep doing it.
Yeah, no, it's like, dog, Gynecomastia did not give you the fucking bar piercings or the fucking collar. That's COVID could do a lot of things. It can't do that shit.
The vaccine made me grow cat ears.
Oh my God. All right. This is probably not the worst place to stop for a moment.
Yeah, let's take a break.
I'm gonna.
We had just talked through different modes of testosterone administration.
Yeah. We were kind of in the middle. There were like two others ish. There was I think I don't know if we fully talked out transdermal and then regular old injections with the one I
they can all work
now, right?
Interchangeably. Yeah, there's gel patches, injectables. There's an oral that I mentioned was unfortunately really hard for anyone without good commercial insurance to afford. I think
Okay.
that like in terms of valuable things I can say about managing testosterone, hormones in general, more is not necessarily better. It can sometimes be faster. Above a certain point with testosterone, you can get aromatization back to estradiol. So in particular with high doses of testosterone, that's something to be aware of, that you can get kind of what's called paradoxical feminization.
Just to be
How does
clear,
that
Michelle,
work?
this whole thing is recording, so I'm just going to edit out whatever we don't have.
So actually all testosterone is made, from estradiol, basically, or from progesterone. Like there's enzymes that can convert between estradiol and testosterone in the body.
Is there like why do we have those enzymes, and why does it work that way? Do we know?
I mean, men and women aren't that different. We have some of the most muted sexual dimorphism of any mammal, let alone compared to animals in general. And every human being has testosterone, estrogen, and myriad byproducts, metabolites, and precursors that are relevant to different aspects of health and physiology. And when you think about how these systems evolved, it makes a lot of sense. Like there are just sort of these biochemistry pathways, and the things that they produce and use happen to work with other signaling pathways. And over many generations, those things develop more and more specialized roles that, often overlap.
Yeah, it's well, human fetuses are female by default. So there's at a certain point in development of the human fetus, a little switch either goes or doesn't go, and often, and probably for actually all of us, the switch goes only to a certain point. It's not binary. It switches on a little bit. Yeah. So those and then those pathways start working, and you get the different genders coming out at the end of 9 months. With cows, there's an interesting thing called free Martinism, which is where cows give birth to twins a lot, obviously, because we have bred our livestock to be as productive as possible. So twins are very common in livestock animals, but cows give birth to the same kind of twins that we do. They'll have fraternal twins, which are sometimes different sexes, or they will have, identical twins and fraternal twins that are the same sexes. So same setup as us, but they have an interesting thing where if there are twin cow fetuses of different sexes, one male, one female, the female fetus will always absorb testosterone from the male fetus. And this is because cows are default male, unlike humans, which are default female. So every cow fetus is default male. And when the cow gives birth, she will give birth to two healthy calves, but the female calf will be masculinized to the point where she is usually infertile. And sometimes she can still be a milk cow. It kind of depends on what level of intersexism she has acquired. But she usually has masculine traits, that she acts a little bit more bullish, and she's just kind of a dyke. And it's called a free martin, and that term was actually used in Brave New World to refer to infertile females that had been genetically engineered to reduce population. So that's something that just occurs all the time in nature. You get actual full-scale transition, not gender transition, but you get sex transition in chickens quite a lot. Yeah. Older hens will often just turn into roosters if they stop laying. And they'll go full rooster. They will grow a comb, they will grow spurs, they will grow the sharp sword-like feathers on their neck, and they will start acting like roosters, including mounting other hens and crowing.
I think that would suit our oldest real good. We'll keep an eye out. Oh, we have chickens now.
Ooh.
Oh, hell yeah.
Yeah.
God, I love chickens.
They're amazing.
They are little guys. I kind of wanted to ask, two big picture ones, because a constant one that you've been talking about, and I know we can't universalize this, it's going to obviously have a sort of different connotation depending on state, but not just that, if you're doing international shipping, etc. I wanted to talk about the cost of DIY medicine, maybe to a more specific extent, the sort of bulk people, or the bulk suppliers some people buy from, etc., and basically how cost prohibitive DIY trans care can be. One thing that's kind of seeking to rebrand it right now in the modern moment is VC people basically getting big buy-ins of their own money to basically start like woke boxable HRT shipments and sales, basically sort of as a upright response. But I don't want to make too many assumptions, but if they are a corporate backed and like front facing company, they may absolutely adhere to state practices regarding restriction of care, which is important. And I think even why I wanted to do this and talk this out thoroughly with people. To that end, like in terms of HRT, DIY HRT specifically being cost prohibitive in ways, could we kind of pick your brain a little bit about that?
What you're taking and who you're buying from, you could expect a do-it-yourself, HRT regimen that is purchased from an international pharmacy to add up to somewhere between, $50 to $300 in out-of-pocket cost per month.
Yeah.
Estrogen is very cheap. Spironolactone is very cheap. That still does add up with, 1 to 3 month supplies shipped internationally. So it's still generally more expensive than, for someone to get the same medications on insurance. Now, there are exceptions to that as well, because some people have really horrible insurance.
Yeah. I could say anecdotally, but these are friends in the United Kingdom. They're like, this isn't just like a thing that like the poorest of the poor face. It's just also like, even if you do everything above board, you make decent money or whatever. Let's say you live in the United Kingdom. This is a country that is like jettisoned. I don't know if they've resumed the program. They've had plans to do so. They haven't.
Still pretending that there's some kind of process that needs to take place. They're still hurting those kids.
But I mean, for HRT, absolutely. The Tavistock Clinic, HRT supplies and new admissions, some waiting lists are cumulatively coming up to what? Someone said like 30 years of wait time?
Goddamn years.
Fucking insane. And phalloplasty, just a whole medical surgical process has been stopped whole cloth, like in the first half for a lot of these guys.
Good news on that front. I've gathered that is actually being resolved. But a whole lot of guys were just left in the lurch between surgical stages without clear information on, hey, when are you getting your surgery? Which, just to give some context, for phalloplasty, that often means you're stuck with a urostomy tube. You have additional grafts or significant genital reconstructive procedures that haven't been done yet, or you haven't gotten an erectile prosthesis. So it's not just, your genitals aren't finished yet, which is a problem enough on its own. You have to deal with the very real medical risks that come with, say, prolonged suprapubic catheter use.
Mm.
It's not a benign thing at all. It's not a matter of, oh, well, this isn't an emergency. You can wait a little longer. We've left people in a position where they're at higher risk.
Yeah, I was just going to follow up and get Eliza just to ask, what is that previous one you just mentioned? The
long-term catheter use. I was just going to say that I was hospitalized with a bladder injury a few years ago. I had a catheter for, I would say, a month. And at this point, 4 years later, I still have bladder problems. I will have bladder damage for the rest of my life. And that's just because you will get urinary tract infections constantly because there's a highway directly into your bladder. And it fucks up your urinary sphincter. It fucks up the bladder muscles. Your body is constantly fighting the catheter to get it out, so it hurts. It's a whole thing. It is not a joke, and it is not casual. It's like a really, really huge problem. And if you want to leave the house, you've got a piss bag strapped to your leg, straight up.
Yeah.
So,
and that's a whole country willing to just do that, and not just that, to a specific discrete population. They don't even have to do it to. And honestly, that's kind of how policy is doled out now. If you get the right think pieces, if you get the right log cabin op-ed, we kind of see it in the modern moment. I do hate dating things, but as of now, Washington Post, LA Times, New York Times have basically dipped their toes into, well, maybe dipped their feet, I should say. It's not a full-on blitz in that they've also had stuff by Jack Turbin, et cetera, ran in those in favor of affirming care. The current whittling down model is juxtaposing discomfort and the premise that most bigotry happens on, which is that the edge cases, the exceptions to the rule, actually define the rule. This is a consistent constant throughout trans care, trans medicine, and arguably medical care as it relates to any minority. God, just recently they stopped race norming in the NFL. That they quietly shuttered that, where it was basically like phrenology shit being applied to a population of, a lot of black players, a lot of CTE involved.
You have less brain to lose.
Exactly.
Yeah, it's pretty easy to extrapolate the overall medical mistreatment of the African American community into probable mistreatment of a lot of athletes at that level who are seeing doctors for injuries and maybe being told, you're fine, or some shit like that.
I mean, it's down to policy now. A decent way they've been able to argue against it, ACLU specifically, against some of these rules and laws, is that these are non-constituent backed laws that, for example, high school trans participation, et cetera. I'm not going to get into the weeds on that, but basically they're throwing millions of dollars to keep maybe one 7th grader out of swimming or soccer or softball.
Yeah, they're trying to institute programs of mass medical rape of children. I mean, participating in athletics.
State coercion, and yes, genital inspection. I would, having been in childhood and teen sports, I'm going to assume their good faith argument for this is not unlike, getting a physical or whatever, but for a specific and spurious reason, we have to make sure you are what you say you are. I think in terms of kind of, I wouldn't assign a 1-to-1 with the racial dynamic, but it'd be segregation.
For me to examine a patient intimately without cause is sexual abuse.
I mean,
that's what they're trying to do to entire states of children, not even just the trans ones. Just the ones some other mom has a grudge against because they run too fast.
And not just that, it's people who are kind of Facebook poisoned or otherwise over engaged into the culture war, to the partisanship that basically has competing political orthodoxies acting like sports teams versus people that want to have substantive solutions for their constituents. We all fucking lose.
Everyone does. I mean, you can look at polls. Even majorities of Republicans oppose this shit. Not to throw them a bone, but
it's poison.
Yeah. And you have to ask, like, how does a society function if you try and actually implement any of these rules? And the answer is, of course, it doesn't, which is a secondary goal, is to break everything. Which, and then, of course, gets projected onto us as well.
Yeah, various. I'm not going to get into them because they're not worth dignifying, and I think they're permutations of very old bigoted feelings that just get reframed as some sort of woke and altruistic means of saving people from themselves. We've seen this for years.
It's been secularized, which is new and disturbing to me. In the last 5-6 years, they've really dug into that psychology angle of, we have nuanced concerns about whether we're really doing the best for people. And it's been really successfully obscured from the underlying religious reactionary ideology that's bankrolling it.
That's a really crystalline way to kind of explain it to some people, I think, because I hadn't really thought of that term secularized until you said it, but it's very accurate to what we've seen over the last 5 or even 10 years, maybe.
I mean, there are a lot of sort of secular movements that were always sort of jokingly said to, like, secularism is its own religion or whatever. But when it comes to the sort of economy of thought and air quotes persuasion, it typically uses discrete groups of people, oftentimes seen as an other, as sort of a neutral field onto which to cast this debate. When you know how it relates to our recent past and even further back in our past, the air quotes debate around Section 28 in the United Kingdom, etc., was bipartisan. It was secular. It was conservative. It was all of the above, and yet, people think it's actually removed from the past. It's this whole new, different thing. I would argue that
that's helpful to consider. Yeah.
That most of
there has always been that trend, certainly in the pathologization of homosexuality in the 50s and 60s.
Yeah. Like even
it wasn't for religious reasons they lobotomized people like us.
Yeah.
Or at least not with religious explanations.
Yeah, there's many risks people face going into that, even DIY, HRT, this or that. Sometimes even speaking openly about being in a trans experience. We do that in the southern states. Highest single concentration of queer and gay, LGBT, etc. Bodies, because that's where the most people are born still. And go figure, that's where the most conversion therapy, now their rebranding is reparative therapy, where most interventions are called talk therapy, but in the South and Deep South, exploratory therapy is the newest one. Where it's like, are you really trans?
Let's really dig into this here.
It's basically branded this way, but in those states specifically, it's going to be a religious body. They'll say it's talk therapy, but a lot of those religious bodies, etc., still use the physical interventions. If anyone don't want to hear this shit, by all means, mute. If you're listening to the pod, this shit fucking sucks. Air quotes, or the content warning. Yeah, there was a Vice story some years ago I'd read where they talked about nationally. Well, what does it look like in terms of sort of coerced detrans, air quotes, care like this? And it's like something like 63,000 to 65,000. It rounds up to people in the United States through talk intervention, physical intervention, etc. Some of the physical interventions involve being strapped down to a fucking chair, being shown pornography, being covered in packets of ice to just shock your system. Electroshock therapy, which I'm not going to go full on in against electroshock therapy. I've heard there's some legitimate use.
Electroconvulsive therapy. This is just shocking people to make them feel pain. Yes.
This is just legal to do to a type of person in this country, to do this barbaric shit. It has not been fully outlawed. I wouldn't doubt that a lot of the Alabama outcomes, especially, don't lead to this. We've seen in southern states a lot of the pray the gay away churches frequently shut down and have people leading the congregation actually come out as gay and then do their little Roy Cohn apology and click their heels together 3 times and all is forgiven. There's documented history of this happening consistently and constantly. A lot of these people have been elevated to the fore to speak in a clinician aspect in a lot of these op-eds. I don't want to go into the name game or the specific naming of them. If you have social media and you know a trans person, you're going to know this milieu of names, and you're going to feel nauseous and want to just take a massive shit that will never come. It's just reading about these people is like just constantly filling yourself up with bread until you're miserable. It's awful, but they exist.
We talked a little bit earlier about risk, and I think it might be worth kind of talking a little bit about risk and safety, because I mean, things that we know are going on to thousands and thousands of people still around us. We now know for a fact any exposure to conversion therapy is associated with a long-standing 2-fold increase in suicide risk. It's damaging, deadly stuff. We also know pretty much across the board, HRT, regardless of really how you go about it, is extremely effective and safe. It's life-saving care. It dramatically reduces people's risk of suicide. It's a decision that an individual, one way or another, has to make for themselves every day, week, month, whatever interval, for some time to do anything permanent to themselves. And ultimately, there are specific known risks about estrogens, testosterone, anti-androgen medications. But if you look at the big picture, and if you look at what trans people are up against, the most dangerous thing about self-meding is driving your car to the post office to pick up your prescription.
Yeah, that's the thing. Like being out there in the world. I'd argue, yeah, stigma, cultural forces, violence.
I think Liz was referring to the fact that you're very likely to get into a traffic accident than you are to get a blood clot.
I'm in tunnel vision mode. But
I mean,
fair enough.
But if you consider what we found for the protective effect of estradiol against COVID, and the fact that our government has left us all to repeatedly be reinfected by COVID, I can't even say that the medical risks as an absolute stand hard against estradiol.
That's right.
I mean, hey, that's why we had all the conservatives pink pilling themselves after all.
Testosterone makes me physically stronger, which allows me to punch my way out of dangerous situations and also to destroy enemies. So who can say whether it's bad or not?
Yeah, if you take a little testosterone, it basically is like, if you've ever played Mario, there's a mushroom that comes out of the top of a large brick of some sort, and it makes you slightly taller. Mm-hmm. And then you're able to jump on Goombas and kill them much more efficiently or faster. You can navigate to different parts of the level. Mm-hmm. This is why a lot of trans-masked people engage in this process.
Fake, luxurious mustache.
Yeah,
hammering ineffectually against a stack of bricks, and someone else will just come along, hit it with their head, candy comes out.
You're inexplicably a journeyman plumber. You start to resemble Bob Hoskins. This is what comes with the territory.
You have a retirement pension.
It's incredible. In terms of terms of this, like I kind of want to get past the negativity of thinking about like, I mean, I feel like we're not going to say anything specifically new with regard to trans threat faced by society. If you are interested in DIY HRT, you likely don't live under a rock and you are aware of the naked animus and contempt that most people feel for transgender people, whether it be in weird, sort of benign ways where it's not necessarily completely harmful, but you live in a society in which you are another, or in many cases, a second class type of person, to the more fiery rhetoric, whether it be dominionist Christians, whether it be government forces that are really, really looking to kick ass in the midterms, to a group of media individuals and journalists who are, for the most part, I've known maybe a handful of good journalists, but for the most part, they're the scum of the earth that deserve no mercy and are godless people that worship a stone ape god that is pointless. They're pointless. They deserve all of the hatred and derision that is given to them. Couldn't have happened to a nicer group of people. That said, it's all dog shit. What is important is sort of why you're doing this. Like, in terms of outcomes and feeling better and being alive, like, obviously this is deep preaching to the choir moment, but Liz, like, why does someone want to go through any of this? Like, you're explaining this to an alien. Why do
my brain work again?
Yeah.
So that's a big part of it.
Mm-hmm.
I don't think I'd be alive or practicing medicine today if I hadn't started HRT. It's a different experience for everyone. It's something that people can also start and stop if it's not for them. And I think generally people who end up in a position where they're asking, should I be on HRT? That's not a question that really goes away except through experience and self-knowledge. You build that knowledge by, actually doing things. There isn't some mind dojo that you can duke it out in forever where you're going to come up with the perfect right answer. Whether it takes 10, 20, 30 years, it's still going to be probably a question on one's mind. And I've had a lot of hard things in my life, related to being trans in particular, related to having made a decision to come out. When I did that, I didn't think I was going to survive, let alone be able to pursue my career. And it was still better than the alternative. It also didn't need to get to that point. It didn't need to be such a crisis for me. And if I had known, what I know now, I probably would have started a lot earlier. I think pretty much everyone who takes HRT ends up saying something like that.
Yeah,
So
I absolutely would have taken advantage of puberty blockers if they had been made available to me. Because I remember very clearly being, 11 or 12 and thinking to myself, this isn't right. I need a few more years to figure this shit out. And even if I had ultimately decided, not to go on testosterone at that time, which I may have, and I had the kind of mom who probably would have been like, yeah, all right, that's fine.
but there's something, as we said, about steering your own ship and not having to wonder.
Yeah,
Either
and
way.
even, honestly, even just knowing that you have that you are empowered to make that decision for yourself, that the option is available to you. Even if you never end up pulling the trigger or decide that you don't want to, that's incredibly therapeutic on its own and medically significant.
It
The
is.
autonomizing of it,
Yeah.
if you grew up understanding that this was a fundamental, not like a choice, but this was something that everyone, some people go through, that it was just a
I
normal thing.
didn't think clearly about my gender identity at all until I understood that I could actually access transition and have any hope of surviving.
Right, and I think that that's what these monsters are trying to prevent. They are trying to prevent children from knowing that they even have the option. And
I mean, if someone who had been in a position where I could have trusted them and had put this question to me at basically any age after I don't know, 8 or 9, I would have wound up with the same answer.
Yeah.
It's that foreshadowing of possibilities that I think is really, that's really the outrage here.
Yeah, I'd say since I guess we're kind of first personing, I don't want to get too exhaustive, but I'd say for myself, I have more of a weird philosophical premise, but basically, why I even engage with wanting to do that was just mainly a repressed thing. It was a thing I kept down because I knew the realities of the time. I knew the people I was dealing with. My parents love me. They are kind of salt of the earth, I guess, working class types that kind of now enjoy a decent middle class to lower middle class. I only say this because it's ebbing up and down for everyone. What the fuck that even means right now? But my folks had 3 kids, and they did the best they could. But I think part of transness and also understanding self-actualization is knowing and feeling out people and vetting people and trying to have hope for the people in your life, but also realizing, even if this sounds pragmatic or pessimistic, everyone could turn on you on a dime. This is sort of the illusion of the American nuclear family. They can all reject you and throw you on the street. In Eugene, Oregon, when I lived there was just a whole row of like homeless LGBT kids that basically got thrown out by their deadhead parents that were thought to be so lofty and accepting, etc. But the bus stop was just full of these fuckers all day, just in the hundreds, walking around aimlessly, not being taken care of by their family, sleeping under bridges under bitter cold, living a destitute and needlessly precarious living situation. Just the ugliness of the world laid bare. My whole reason for even going into HRT and approaching it is like approaching anything. I don't believe that trans people hold a monopoly on the idea of self-actualization, of the idea of making yourself whole through any and all available means, medically, holistically, etc. I want that for trans people because I want that for everyone. Like, I want that for myself. I feel like society teaches you in many ways and whittles down that instinct, not individualism. It is the making of yourself to be the best form of yourself, to interact with the world, to be healthy as yourself, and to have something to offer people at the end of the day, to be in a world with others and to bring everything to the table. Everyone needs that. The eliminationist premise against this exists because we are in many ways one of the most significant like questions to the human experience. That's not me blowing smoke up trans people's asses. It's just like, sure is a lot of money to spend on this problem.
Apparently, that's what people make of us, it seems.
Yeah. And
we didn't ask for that.
Yeah. And I mean, there's basically blood libel equivalents now where everyone is basically being assigned fault because I don't know, a New York Times reporter has come across the magical thinking that Tumblr like magically snapped and made a whole generation of people transgender apropos of nothing, when it's instead the preponderance of information that is available to all people that is happening to trans people at the same time. It's It's the left-handedness chart, repeated ad infinitum.
We get to know ourselves and each other earlier, more clearly.
Yeah. And it's not, it's like, guess how many more of everything there are nowadays. Not, you know what I mean? In those terms, speaking, where people are like, oh, there's so many trans, it's like there always have been.
Point of order.
Mm.
There are not more trans people now than there used to be.
Exactly.
We're dealing with two things that are products of very recent history. One of them is that we are witnessing a population bounce back from the AIDS plague.
Yes.
It's inestimable how many queer people, but specifically gay men and trans people, died during the AIDS plague, and they were just gone. And that lowered the percentage population for many decades. And we are now seeing that population rebalance itself, because this is a natural human thing. There are always going to be a percentage of gender nonconforming, intersex, and trans people in the human population. It's a feature and not a bug. There are a lot of, evolutionary psychology theories about this, and I'm not going to go into them because we could do a whole other episode. It's very interesting, but literally there are no human societies that do not have some sort of designation for a third gender, for multiple genders beyond just a third one, for gay people, for trans people, and usually, not always, but usually, those third gender designations are related to a shamanistic class or a religious class of some sort. And to a certain extent, a lot of the complaints about trans people are exactly the same complaints about trans people that are written in the historical record from ancient Rome. Stuff like the priestesses of Sybil are really annoying. They wear too much makeup. They're strident. They make too much noise. I don't like their parades. Literally, I don't like their parades was a major complaint of the Roman citizenry of the gay and trans priesthood. And medical transition reaches back to prehistory. And not just medical transition, but gender confirming surgery, even on cis people. There was a ancient surgeon, Polonius, I cannot remember his name now, I'm going to have to look it up, who has in his, historical record, a surgery for gynecomastia on a cis man, because this guy had tits and he didn't want them, so he got them chopped off. It wasn't a big deal. It had nothing to do with gender, except that this guy probably felt better after he got it done. And he had it done under the general anesthesia that they had available at the time, which was, basically opium and opium derived medicines and, whatever herbal stuff, and alcohol, obviously. And they used a lot of the similar techniques as we do, even to the extent of cauterizing wounds with their surgical equipment. Mm-hmm. So, I'm kind of an armchair scholar of this shit. But medical transition isn't new. Trans people are not new. You cannot get rid of them. They are going to be around forever. Population estimates are like 1 in every 100 people you meet is trans. And same goes, 1 in every 100 you meet is intersex. That's exactly the same as number of redheads that you know. So, and there are probably more of us than that as well, because of course those numbers are going to have to be undercounted, because not everybody who is trans is going to answer a survey saying I am trans. So undercounting has to be sort of worked into your mental calculations of this stuff. But I think the difference is, even though trans and gender nonconforming and queer people do have a history of persecution in different parts of the world and different histories, what is new is that the Roman Republic had a coin with Sybil's head on it. And, they were just sort of recognized as part of the Republic. And even if Roman citizens, who were all landowning men, were writing each other letters or writing in their histories that these people were annoying and that they didn't want them around, and that the castrated priests of Sybil were not officially Roman citizens because you couldn't be castrated and be a Roman citizen, they were still not taken to the pits and thrown in. They were not taken to, the Colosseum and fed to lions. They were not persecuted on a large-scale basis the way that we are seeing now. So those are the differences. It just bugs me because it's such a non-issue. There's nothing you can do about gay people or trans people or queer people. You can't get rid of us. We're always going to be there. A certain percentage of us are going to be born for every number of babies that are born. Don't worry about it. It doesn't affect you, Like, chill out. Do something
For
else.
some of us to be born who don't have to still be hashing this shit out with people when we're in our middle age,
It's so boring. I'm so bored of it, right?
So old.
I mean, yeah, that's the basic like decent person-to-person conversation I feel I've had a few times. I've went back to basically manual labor again as I work on my stuff. Hell, even the previous name of the pod sort of denoted the fact that we're all working on other shit while maintaining this consistently. I think about it more than I have, just because the nature of people I've known experiencing more pronounced getting in the face about this shit in a modern moment, and then the oh dear, oh heavens sort of rhetoric in the media from op-ed writers and etc. Specifically like the log cabin Republican types that then say, well, if you hadn't gone so overboard, now we're actually facing this. And yeah, to move on, Lucy had a question. Lucy, what's up?
So one thing that I was wondering about is a somewhat new approach that kind of splits the difference between going a traditional medical route and doing the DIY route, which is hormones is like a service that you get through the internet. So I think there are like two prominent services. One's called Folks with an X, which is going to make me have an aneurysm someday.
Absolutely. Oh, yes.
And then there's another one called Plume. And the concept behind these both, if you haven't heard of them, is that you pay a monthly fee. And what they do is it pretty much covers the cost of like your ongoing labs and stuff. And they'll have a doctor. Sorry, what?
It's called the direct primary care model. So it's a concierge-based or subscription-based kind of all package included medical service. And some patients it's expected need more investment, some less, but it gets evened out across the whole pool.
Right. I didn't know there was already a term for it, so thank you for introducing that. And then like the cost is like both of these quote around $100 a month. And that doesn't include like the cost of your prescriptions that you get, but and they aren't covered by insurance either because it's just like upfront you have to pay cash for these. So I was wondering, do you have any opinion on these concierge services? And do you think that they are a positive development, or do you have some reservations about them?
I think it's a mixed bag. I think, of course, the corporatization, the kind of, the aesthetics around it, the glitzy aspect of it, that's all, I kind of want a much more centralized universal medical system that still respects autonomy and diversity. That's my bias. I do have to say, like, telemedicine and the accessibility of services like this opens so many doors for people, especially folks with significant agoraphobia. No one in town who will see trans people, or maybe they're like, there's one creepy guy who will string everyone along for a year plus for hormone. There's a lot of situations like that. $100 a month plus the cost of hormones can be pretty steep for a lot of people. It's not a bad deal compared to self-medding, and gets you access to someone with some medical training and attention who can consult with you. And for most of the management decisions here, having an exam might be helpful, but it's not the most, it's not the make or break factor for delivering quality care. So overall, I've heard positive things. I haven't heard any nightmare stories. And I think it's a feasible way to deliver care. I think that certainly money's being made. It's a venture. This is a bigger problem with our system.
I mean, off the top of my head, as a individual consumer and someone that like constantly tries to look for ins or whatever, as soon as I hear HRT as a box service, I think of medicine subsidies and costs being flattened to such a way that works against the consumer. I don't just think about HRT when I think about this. I think about like insulin and how we can't even have like a decent fight unless anything has changed substantively to like cap the price of that to a not dog shit price, or at the very, like, we can't even nationalize healthcare, which is a whole other deal.
Right.
Despite the fact that like the premise was whittled down to the right to access healthcare, right, which is a nice little linguistic term, which means you do have the right to buy this in a marketplace, and that can mean many things to many people. This is answering your question, right? This is not a non-answer. I have told you you can buy the thing. But the framing device the Dems use a lot as it refers to Obamacare and that health marketplace. Yeah, I don't trust shit like folks just because of its connections to VC and the business model and trying to almost package it like a luxury good.
It's exactly the wrong message to me as a patient.
I would be primarily concerned with how long these things can last, just knowing how fickle VC funded companies can become as well. Like, let's say you start in one of these programs and all of a sudden it shuts down.
You want to get really spicy,
That's
we're
a good
not the ones
criticism.
doing it for ADHD meds.
Oh God.
What?
That is a burning fuse, my God.
I did not know that there was one for ADHD. That seems like playing with fire because like it's usually those meds are like controlled substances
little
too.
model,
So
but-
that seems
That seems very legally gray to me. Yeah.
I would be extremely anxious, and I'm someone who supports broader access to, literally, I think people really should be able to get whatever the heck they want and involve me for guidance if they want that, you know. But the model that I've heard about this, it really seems like a not defensible diagnosis and management process that, I mean, I hope they can carry it out because maintaining ADHD meds is an absolute nightmare. And it's great if that makes it easier for people, but I'm worried that the DEA is going to crush them like a bug.
Do you have a similar outlook for these services since they offer testosterone as well? Do you think that's another concern that people should have before considering using them?
I think if it's not in any sense for performance enhancement purpose, I think that test is sort of ahead of us in terms of how the legal environment may change in the future. At present, I don't know. I don't really have concerns. Like I have to do this thing now. Everyone who prescribes testosterone in the US has this issue now where in the last year, they changed the labeling for the vials from multi-use to single use only. And it's the exact same vial. It's still just as safe or marginally less than 100% safe to draw multiple doses out of the vial, especially if you use antiseptic technique. But now there's sort of a rule that was changed in a spreadsheet that says all of these are supposed to be used once and then thrown away. So some pharmacies are chill when I keep prescribing the usual way, and some will panic and expect me to send a vial of testosterone per week. And after some initial anxiety, because every single one of these is reportable to the DEA, it's tracked, quote, closely, I just said, fuck it, I'll do it. I mean, we're all in the same boat on this. It would break things to start punishing us for this. And the thing about all these regulations is, as a clinician, you're walking around with all of these invisible destroy career now buttons hanging around you no matter what. Your really best defense is to build good relationships with patients, be conscientious about what you do, document it well, make sure that you're doing things for a reason. But it's like with criminal law in the US in general, where everyone is constantly breaking laws all the time. I'm supposed to prescribe 30-day supplies of some medications, but then they only come in 45 or 60-day supplies. And the pharmacist is like, send another prescription for this amount. And I do, and it's fine. So that's one of the other weird things about the US.
So as far as that new ruling on the single use for testosterone, who made that change and why?
The FDA made that change. It was sort of, I don't clearly 100% understand this yet, but it's really literally just a value in a spreadsheet that got changed. And it's sort of a byproduct of the FDA investigating and cracking down on compounded injectable hormones because of a completely unrelated issue with severe and weird bacterial infections from a couple of these compounding pharmacies that were not using good technique and had contaminants that got introduced to the vials. This just incidentally affected the labeling of commercial grade testosterone vials and estrogen vials too, I think.
So I take it these sort of changes aren't made with the consultation of folks like you that actually do the prescribing.
Yeah, they're not necessarily even intentional. Little regulatory changes like this, it's really just something got moved in a computer, and now some people are like, oh, that's nonsense, whatever. And then some people who are maybe new at the pharmacy or maybe just a little bit more scrupulous, they're like, oh, that's different. Oh, this is a problem. We got to change this. And then you hash it out, and mostly it makes no difference either way.
I mean, oof, wow.
That's like one of 100 similar situations you deal with a day, like doing clinical medicine in the US. And at some point, you either start to lose your mind from it, or you accept that you're not going to see the bullet with your name on it, and you want to just do your job as best you can.
Yeah, that's the American experience in microcosm, albeit with medical professionals, especially in the modern moment, not just the COVID era, but also the current moral panic being whipped up. That's medical professionals, that's teachers, it's parents, it's children. That's kind of the animating principle is thinking about a lot of this stuff tonight. I don't want to get too in the weeds, but it's I've been at this for 10 years about now in terms of actually doing HRT. It went on, it went off. I had to detransition for really bad, shitty reasons. But I'm taken aback. I've been looking into history and a lot of sort of past citable information about how bad it also could be to temper these feelings. But I think this is like the most I've seen it once. I don't want to obviously get too personal in terms of your own practice or center with your patients, but like in terms of their concerns, have they been more vocal about this than ever before, or has it been different? Are they having a lot of questions?
It's complicated, because I'm in two different roles. I'm a trans person who's fucking terrified and angry about this, and I'm also a doctor who's terrified and angry about this, and simultaneously I'm responsible for being present for the person I'm there for. I've had a few conversations that are more direct and a few that are less direct with different people. I've had situations like, well, surprise, surprise, someone has significant insomnia or anxiety now, and maybe we both kind of know what's up if these are people I know well. It seems a little bit, it's hard to bring up, especially I think as the clinician. I mean, they don't necessarily know my politics or have an ability to assume what level of tapped in I am. You know, just because I'm trans, I'm in a different professional setting. But it's also hard for me to bring up because it's not necessarily, I'm there for what they're there for. I'm not necessarily there to be consumed with this stuff, even if I can reasonably infer it's on their mind too. But yeah, it's been hard for everyone, and there's some fucked vibes out there.
Okay. Just kind of wanted to go around real quick. It's kind of, we do want to wrap. We kind of like wanted to get out any last questions that may be lingering or on anyone's mind. Just want to go around.
I think we should talk a little bit about timelines, because this is a thing that really concerns every trans person when they are thinking about transitioning. And there's a lot of really shitty information, even from official sources, about physical changes and the timelines of those changes. So yeah, I just wanted to bring that up. I'd like to start with what Liz thinks is important to know about that stuff, and any experience that she's had with it with her patients.
Yeah, it can take a long time. I think one of the most important factoids I can share, in terms of expecting permanent changes from HRT, which is of course something a lot of people are justifiably or otherwise very anxious about when they're thinking about starting medications to to affirm their gender. You can start to get permanent vocal change on full strength testosterone replacement on the order of about 3 to 4 months in. And that's got some published data behind it. People's experiences, again, may still differ from that because this is all neglected as a medical field. With breast buds and estrogen at full strength, dosing, you can expect breast buds that wouldn't go away with cessation around 6 months in. Lower doses generally result in slower changes. Older people generally have slower changes, but can still get dramatic effects with HRT. The published sort of patient-friendly figures on time frame are often what people don't realize is an artifact of how long we had money to study a question. So if they say something like breast growth over 3 years, guess what? A lot of research grants are for 3 years. More reasonable to assume that with cis women, breast growth can continue and vary, over the course of one's life. And that's what you'll hear from a lot of trans women. There's lots more to say about timelines. It does vary tremendously for different aspects of puberty from person to person. And that's really not unlike cis people.
Yeah, I wanted to say that, as specifically regards breast growth, I've heard, I would say probably most of my friends at this point are trans women. And I have heard them tell me bullshit information that they got from trusted official sources, stuff like, the 3 years thing gets quoted to me a lot. Well, you're going to get all the breast growth you're going to get in 3 years.
Mm-hmm.
And
or you shouldn't ever expect to get past 10 or 3 or...
Right. Yeah, exactly. I've heard that one too. And I want to say, I got breast buds when I was 9, which is actually pretty typical. Puberty starts a lot earlier than people think it does, even for normal kids. And I would say the majority of my changes happened probably between the ages of 11 and 16. But my breasts continued to grow and change size and shape until I was almost 30. And that's not uncommon. And if I ever get pregnant, if I ever have any sort of a hormonal change, either from HRT or from any other reason, and if I gain or lose weight, my breasts will change again, because breasts are one of the most malleable parts of the human anatomy, because they are just fat and some ducts and stuff, but mostly fat. So that stuff takes a long ass time. And I really worry a lot seeing, trans women saying stuff like, if I'm not a D cup after 2 years I'm going to kill myself, or even rushing into surgery. And I don't dissuade people from getting surgery at all, but breast implants are a major surgery and they are a risk. And if you are only getting breast implants because you think that you're just not going to get any more breast growth and it's only been a few years, you don't need to do that yet, is what I'm trying to say. And it's not just about pure growth. It's also the body is in a process of lipolysis and moving fat from one location to another. And as you burn fat, and then eat food that is stored as fat, your new hormones are going to tell that fat to get stored in different locations. And that takes a long time. I mean, even just think how long it takes to gain and lose weight just from exercise or food or stress or whatever. So I always try to take these opportunities when the topic comes up to just sort of put that information out there. Likewise with masculinizing HRT, the majority of cis men cannot grow a respectable beard until they are 30 years old.
Mm-hmm.
And I mean, it depends highly on your genetics, obviously, but it's, Eli, my partner's cis, he can't grow a fucking beard.
My 65-year-old father can't grow a beard, and I can't either.
Ooh. All right. I get a rare chance to swag him out, but I'll throw it in the chat in a minute. But I want to show everyone my dad. All of my gay friends hit on him. He's got a massive beard. It sucks to be all. You don't need to be Mexican. It's okay. You're not Mexican.
I got the genes too.
There you go.
I looked a bit like Serge Tankian.
Just gonna go through it in terms of any other questions, folks. Okay.
I think I have one.
Ooh.
So a lot of I guess what I'm trying to say is when it comes to the education of people who are coming into the medical field as like doctors or nurses, do you feel hopeful that whenever it comes to treating trans patients and dealing with their specific healthcare issues, do you think that the education segment on that is getting better now that people are a little bit more aware of it, or do you think that it's been more stagnant?
Really no, I actually have seen a lot of reason for hope on that front. I see a lot more interest, a lot more openness. With some of these schools, there is always sort of the danger of a faddish investment in LGBT health, LGBT healthcare, doing perfunctory efforts, but even those end up sparking interest in people. Giving permission to even say the word trans out loud in a medical learning setting. I mean, when I was in school, I was eventually out. I was stealth for a bit, and then I was like, yeah, that's not what I wanted to confirm. But even then, like, I would do trans advocacy, and people in the administration would be like, thank you for that work that you do. That has changed a lot. And it's been amazing to see. It's really, I long for not being something special as a clinician. Like that's the sign that something really good has happened, as if I don't have something especially unique to offer to people. Yeah. Even if I'm considered outdated, that would be perfect.
I mean, yeah, that's wow.
I really want to see, people surpass what I've been able to do and what we're doing today for trans people.
Yeah.
I think that's possible for us.
Yeah, I was about to
that's
say.
That's a much more hopeful answer than I was expecting, and I'm really glad.
Yeah, that was kind of the torturous thing sometimes about this. I don't feel like my personhood, etc., has been defined by transness, but like it is a thing I have to actively think about in my life. I think like transgender is a word that exists to explain the political phenomena, describes me as an other as it relates to society. I think of myself as a woman. I think of sometimes my gender expression, or as being who I am as an action, sometimes is like more genderqueer or whatever, but that's heads or tails. The thing like I've seen in the world that has been amazing is, yeah, obviously there is a massive gulf between individual people and large institutions and massive groups of people, many bigots, many otherwise forming an identity around agitation and just against someone's existence. This will always persist throughout humankind. I haven't, and I don't want anyone to really just sort of give up on that process, though. Give up on engaging with everyone else and the world around them, self-actualizing in any fucking way possible. Like this shit we're going through right now. I'm not going to lie to you. Like, I don't want to be catastrophizing or just pulling my hair out of my head. It's totally reasonable to be scared about the modern moment and to have, you know, many consecutive dark nights of the soul. But I feel we've survived before in the struggle of society. Living as a whole person is wanting more than survival, and not just prosperity at someone else's expense, but working within the larger humanist continuum. You know, these times almost sort of demand a near nihilist premise to accept the horror of the time you live in. It's very, very bleak policies being enacted and just thrown out at people. The rug is being pulled out from kids. CPS in Texas specifically is thinking of like throwing a lot of these kids into the Texas foster care system, which, you know, I'm not going to split hairs here, is basically like a great big rape factory. There's literally no politically correct way to say that. That is by design. The pain associated with living a certain way is what they want to hammer into a group of people. They want to do this because this is the acceptable way they were able to do things in the past, like segregation, fostering away different types of people to erase their identity, cultural, ethnic, etc. That's what they've always done, but people have always survived. They've persisted. They've moved from strength to strength. None of this shit is going to be solved overnight. And this is symptomatic of a genuine social rot that we're all at the mercy of. The world is being pushed to the brink. There is a lot of cause to feel fear, abject terror sometimes. This has been the most in my life. Like, people have gotten in my face about shit, where I found out that a lot of relationships I thought were real were very conditional. And that's life, period. You're going to face this in a very specific and discreet and heightened way because you're another. It's not great, but it is what it is. I want myself to survive. I want you to survive. I want people to look back and have a collective past where we can say to one another, as other people have said to me, where I've, you know, I didn't know what to say. I've met people that were old and never got the transition, that would still go by their feminine name, and I'd meet these people in Walmarts, and it is like a psychic undertow. You think of someone trying to be themselves at all costs, and they can't. You can. You have those options. You have a way forward. Sometimes it might mean hiding. Sometimes it might mean trusting someone when you never would have before. Sometimes it may mean not trusting everyone in the way you once did. But at the end of the day, You're making yourself better so that you have something to offer to someone else. And in turn, they can have something better to offer someone else. Society can just be made of people trying to touch each other's lives in this way. And it is significant. At its core, it is love. And however people may feel about it, working in the service of that love of life is the finest thing one can do. To that end, I really want to thank Liz Brown. This has been illuminating. I've learned a lot. I feel we all have. If you know, there's a lot of this shit. I've been in this for a while, and I'm still learning stuff. But I really appreciate your time. This was very wonderful.
Thank you all so much. This was amazing, and I really appreciate the chance to talk with you.
Yeah, no problem. I am Michelle Perez, producer Jake, a buddy, Eliza, also a buddy, Lucy, a buddy, Ruben, a buddy on the lam, and Liz, a buddy of the medical persuasion. This has been the Pig Iron Podcast. Share with the friends you may have, share with the enemies you may have, unless the enemies are evil.